Okay, let's get started. I'm Takaki Yoshimizu from Shizuoka in Japan. Today, I'd like to talk about his full endoscopic transcambing triangle lumbar interbody fusion by using UBE. This slide is today's contents. I will talk about concepts of KLIF, how to UBE KLIF, clinical results of UBE KLIF, limitations of UBE KLIF. As you know, various approaches exist for lumbar interbody fusion. From this green area, we can access the disc without facet invasion, unlike this blue posterior access. I emphasize the difference between these two areas in the point of no necessity to expose dura. Dural tear is a threat for spine surgeons. We always want to be free from this stress. But endoscopy can be applied basically to the posterior approach. Let me express about concept of transcambing triangle lumbar interbody fusion. We call it KLIF. Transcambing means accessing to the disc from posterolateral and inserting cage from extraframen. This method has an advantage that the dura does not need to be exposed, but the decompression is done indirectly. I will talk about my thoughts on whether TLIF or KLIF should be applied. We experienced remarkable back muscle atrophy after full endoscopic TLIF using UBE. The patient was 65 years old woman with a complaint of intermittent claudication. 1 year after the surgery, there was no loosening of the implant and the intervertebral bone formation was very good. But there was marked atrophy of the paravertebral muscles, and the patient complains of back pain. This suggests that TLIF may not be minimally invasive to the muscles, even if it is performed using endoscope. And in addition, there is a difference between TLIF and KLIF in the nerve protection during cage insertion. TLIF requires protection of the dura and nerve root simultaneously. On the other hand, KLIF only requires protection of the existing nerve root. Multi-aspect protection is not a good match for endoscopic surgery. This led us to believe that KLIF is a more suitable approach for endoscopic surgery and less stressful for spine surgeon. Next, I discuss whether uniportal or biportal techniques are better for endoscopic interbody fusion. In Japan, there are several doctors who use the uniportal techniques for the KLIF. In these methods, the original tubular or semicircular retractor is used for cage insertion. The angle of cage trajectory is more oblique and requires a different skin incision than pedicle screw insertion. We wondered whether the size of the cage was really sufficient for indirect decompression in these methods. Therefore, as a solution to insert a big cage, we decided to enlarge Cambin's triangle by removing the upper part of the superior articular process. Chisel or drill would be useful for resection of the superior articular process. Biportal endoscopic surgery does not use a cannula or a retractor, so ordinary spinal surgical instruments can be used. This is a great advantage over uniportal endoscopic surgery. There are two advantages to resecting the SAP, or in other words, preserving the inferior articular process. The IAP protects the dura and guides the cage insertion in the correct trajectory. It is like a guardrail that guides us safety to the destination. We set our goals of new interbody fusion. The key is inserting big cage from posterior without seeing dura. We needed endoscopic techniques to reduce invasion. We combined biportal techniques and KLIF and made minimum invasive lumbar interbody fusion. I will show our procedure with video. Set the portals just lateral from pedicle. Start from base of TP and do SAP dissection with radiofrequency device. Only we have to check, we need to check the facet. We don't need to detach muscles more medially from lamina. Resection of SAP is the key. We need to enlarge convex triangle for safe cage inserting. Cutting line is just over the cranial pedicle edge. After SAP removal, we can reach disc and get big working space. Biportal has an advantage in disc curettage compared with uniportal techniques. We can use bigger size of device like curette and punches for disc curettage. And we use demineralized bone matrix and resected SAP as bone graft. Funnel is useful to bone graft through the portals. Inserting the cage, we can use nerve retractor to keep exiting nerve roots safe. I use fluoroscope supplementary. In most cases, we can insert 12 mm width expandable cage. Expandable has an advantage in indirect decompression. Insert the two cages with the same procedure from the contralateral side. Using two expandable cages is useful for correction of disc height and slippage. Okay. After putting the cage, we insert the pedicle screw percutaneously. We can use portals which for inserting cage just as it is. In this way, a strong intervertebral body fixation with two cages and 4 screws can be performed with 4 skin incision of about 2 centimeters, like this photo, like that. I will present the patient who is 82 years old female whose chief complaint is intermittent claudication. Diagnosis is L45 grade 2 spondylolisthesis. I performed UBE KLIF for bilateral side. I examined the results of this procedure at 1 year after surgery. The subjects were 18 patients who underwent UBE KLIF at a single level and were followed for more than 1 year. The average age was 68 years, 8 males and 10 females, 13 cases of spondylolisthesis, 3 cases of stenosis, and 1 case each of recurrent herniation and foraminal stenosis were treated. The examination items were back pain, lower extremity pain and numbness, recovery rate of JOA score, and bone fusion rate at 1 year post-operation. The recovery rate of JOA score was 78%, and back pain recovery rate was 56%. Lower limb pain recovery rate was 65%, and lower limb numbness recovery rate was 78%. Bone fusion was judged as a request when cross bridges were clearly formed between the vertebrae on CT at 1 year after surgery, and the fusion rate was 61% in 11 cases of 18 cases. Finally, I will discuss about the limitations of this technique. KLIF essentially utilizes indirect decompression, ossification of the ligamentum flavum, and osteophyte extending into the spinal canal, requires direct decompression because correction with cage alone is not effective in decompressing. We need to counter plan for treating such cases. Performing TLIF is one solution as it allows for direct decompression, but we perform KLIF bilaterally followed by endoscopic decompression surgery. This is more intensive, but results in maintaining a minimally invasive approach. And we experienced a patient who complained of side pain after this procedure. The early postoperative CT showed swelling of the iliopsoas muscle. It is unclear whether the swelling was caused by perfusion fluid or the hematoma, but it resolved spontaneously. I have told all contents of today's speech. Thank you for listening. If you have some questions, please contact with me from this address below. Thank you again for giving me such a great chance. Thank you.
Okay, and thanks, Dr. Takaki, and I think it is an interesting topic about the KLIF, and I think it's also interesting, and many doctors maybe have several questions. If any questions, please record it, and we'll discuss it later. Now, and the next speaker and Dr. from India, I think maybe he had problem. He have the matters of families, so he absent, and now we just invite directly the Dr. Zhang Wei. Yeah, we all know that Zhang Wei is so famous in China, and he is a founding member of International Society of Unilateral Bipolar Endoscope, International UBE consultant member of UBE Master Science team, and also a member, very, so many members of the different society, and now he give us the topic is the cervical UBE. Welcome, Dr. Zhang Wei.
Thank you for Dr. Nong's introduction. I'm Dr. Zhang Wei from China. Maybe I'm the last speaker. Thank you for everyone's keeping up. Today's topic is cervical case by UBE. The content includes the indication, basic anatomy, tools, anesthesia position, location of the portals, and the surgical steps, and the third one portal, and the cervical sliding technique. Indication of the UBE cervical includes the keyhole and the ULBD for the CSM. It is similar to the lumbar procedure. The cervical case also have its own worker space surrounded by the rotators longus, rotators brevis. You can see the workspace and the muscles around the workspace. But there is also the anatomy trip. You can see the left picture show in the C5, C6. We can see in the midline the flav ligament is absent, but in the C6 and C7 the flav ligament is intact. The right side is another case. Nearly the majority of the level, the flav ligament is intact. So after we insert the endoscopy, we can see the flav ligament is absent, so it's very dangerous. You can see the spinal cord directly. There is no flav ligament. If you insert the root, the first root in the midline, if the patient has the anatomy trip, it is very easy to damage the spinal cord. And the cervical case equipment include the we need the simple and small number of the device, include the endoscopy, radio frequency, and the special tools, small size Kerrison Punch, and the high-speed drill. Zero degree is recommended by the Dr. Sun, and 30 degree is used for the difficult case. But in my clinic, I prefer to use 30 degree endoscopy because I often use this 30 degree endoscopy to observe the ventral structure of the spinal cord. Radio frequency, this is a small size one. It is showed by Dr. Tian Dasheng. This small size radio frequency is used to do the bleeding control around the nerve root. We call it the nerve front. And the small size detector, the UBE semi-tuber for keeping the outflow fluidly. And the protective sheath for removing the osteophyte around the nerve root. You can see we insert the transparent protective tube to protect the nerve root. Then I insert the high-speed drill along the tube to remove the osteophyte. For Kerrison Punch, I use 1 millimeter and 2 millimeter, but 110, 130, this kind of type of the Kerrison Punch. And also I use the 1 millimeter or 2 millimeter, the curved punch. Because why we choose this angle, we can master the dural touch technique. A high-speed drill. The principle includes the short handle and nearly no exposed drill root. About 2 millimeter, 3 millimeter is good. General anesthesia. We can control the blood pressure and deep anesthesia to get the excellent muscle relax and the jet plane position. For the location of the two portals, the left picture shows the Dalton's method. The horizontal line is located in the disc space, and the perpendicular line is located in the mid margin of the pedicle. But I prefer to the blue one. Blue one is located in the midline of the lateral mass, especially for the keyhole procedure. This is a lateral picture. The 2 point, the distance is about 2 centimeters. First, I prefer to build the work bottle. The first rule is I often locate it on the surface of the laminar. It's very safe. Then the endoscopy and the radio frequency meet with each other in the midline. Viewpoint is a very important anatomy. We start from viewpoint. I often use the size of the diamond bore to measure the decompression range. The lateral mass joint. We often insert the lateral mass joint screw. So the lateral mass joint is very clear. The V point is the start point. The lateral margin of the flav ligament is a dividing line. You can see the lateral margin of the flav ligament. There is a member on the surface of the nerve root. We often find this member. You'd better not mistake this member as a dura. This is the decompression area and the range. The lateral wall of the pedicle is also important. We can see it, and we also can use the hook to touch it. It can make sure the decompression range. This is the lateral wall of the pedicle. I also can use the size of the diamond bore to measure the decompression range. In the beginning, I prefer to use the small size diamond bore to make sure the lateral wall of the pedicle and the medial wall of the pedicle. You can see the hole, the two holes. One hole is the medial wall, the C6 pedicle. Another hole is the lateral wall of the C6 pedicle. The left side is the tip of the SAP. So we can know the decompression range clearly. Yes, I can use the hook, or I can see it clearly, the lateral wall of the C6 pedicle, and then the medial wall of the C6 pedicle. After the keyhole procedure, we can go on the decompression in the midline. At the last, we can see the medial wall of the two pedicle. Then we finish the decompression. This is giant osteophyte in the spinal canal. I choose the contralateral side approach. The motion of the instruments and endoscopy in the UBE cervical case is freedom. You can see I exposed the lamina of the C4 and C5. We can see the inferior margin of the osteophyte. The upper margin of the osteophyte. There is a free bone on the osteophyte. Then I remove the free bone fragment. I separate the free bone from the spinal cord. So is the small size radio frequency is very useful, especially for the cervical case and the thoracic case. We can see the contralateral facet joint and the nerve root. Left is pre-operation, right is post-operation. Cervical ULBD is suitable for the single level or two level, maybe a 3 level, the spinal stenosis caused by the flav ligament. We do the bone work until we see the inner plate, and we can see the proximal insertion of the flav ligament. And then we remove the laminar of the C5 and the contralateral side flexible ligament to finish the ULBD. It is different from the lumbar procedure. If you want to do the contralateral decompression, we often to work from the basement of the spinal process, and we can work on the surface of the contralateral laminar. I also use the transporter in the cervical case, but it's more proximal side compared with the lumbar transporter for the contralateral decompression. But this is a ipsilateral decompression ridge. The contralateral exposure. We can see the surface of the contralateral laminar. Then we insert the first root. To remove the base part of the proximal vertebra is very important, because it is easy for us to see the laminar of the distal vertebra, but we must remove the basement of the spinal process of the proximal vertebra. Then we can see the contralateral side laminar. This case is a C5 and a C6 case. Now we clear the soft tissue on the surface of the contralateral C5. The angle is very good, I think, if you insert the bone through the transporter. We can see the cross section of the laminar, so it's very safe if you use the bone through the transporter. We can clear the contralateral side soft tissue until we can see the V point and the contralateral side, the lateral mass. You can see it's very safe. Use the bone because you can see the cross section of the laminar. You can control the depth of the high-speed drill. Mixing the laminar. It is also the flexible ligament insertion. We separate the insertion of the flexible ligament. Then to mix in the C5's contralateral laminar. is very easier to remove the flav ligament by the Kerrison punch through the Zhang's portal. This is the contralateral side flav ligament. We remove the flav ligament until we found the contralateral facet joint. This is the contralateral facet joint, and we point. In this case, we also do the ipsilateral, the nerve root decompression. I also create the quarterback key portal for the cervical case, especially for the disc herniation case. It plays a role of the retractor. We insert the key wire to protect the nerve root. Then I do the discectomy. The disc fragment is also be located in the axillary area of the nerve root. Sometimes we often use two portals for two-level or multi-level case, because the neck area is different from the lumbar area. The bone is very short, so maybe I think the two portal is enough for the multi-level case. So I think the cervical anatomy, especially the workspace and the V-point, start point is very important. And the right tools, right operation indication is also important. Cervical UBE anesthesia, we choose the general anesthesia and to get the blood pressure control and the muscle relax, and the position to keep the vertebra is in the horizon level, the precise location of the work portal and view portal, identification of the viewpoint, and how to make sure the decompression range. We must know this content. Thank you, everyone. Thank you.
Okay, thank you. Thank you, Dr. Zhang. Show us the impressive presentation. And we are now, and you do a lot of work in the UBE, not only lumbar, but also the cervical spine, and especially create the Zhang's portal and the quarterback keyhole, use the keyhole. Okay, dramatic work. So, and I think also many surgeons and have questions, but we have a last speaker, and if anyone has questions, please, we can talk about it later. Now we invite Dr. Malcolm from India. Hi, doctor. I know you have dealt with the problem of family matters. Okay, so okay, this is your show time. Welcome.
Thank you. Before I start, I would like to thank Bonds, and it's a very simple lecture on UBE. I hope it is appreciated.
Good morning and welcome to my presentation on UBE cervical spine, a paradigm shift. Before I start, I would like to mention that I have no disclosures to make. Kind invitation, and I would like to thank Master Son, my mentor and guide and friend, for all that he has done for me and taught me. Thank you so much, sir. Management of cervical radiculopathy endoscopically. Preferred approaches in the world are today endoscopic anterior cervical discectomy and posterior cervical discectomy with foraminotomy. My talk today is going to specifically focus upon UBE for posterior cervical laminoforaminotomy. You all know that UBE is a biportal approach. It is a wonderful approach. It has removed all the problems associated with the Sperling and Scoville's approach, which include a lot of muscle stripping and trauma. Today, we are doing everything in a very, very micro, minimally invasive method. What we have seen today is that there is a 93.8% improvement in the function and pain of the patients. With the original Sperling and Scoville's approach, there was a 10% incidence of permanent pain. But however, we have not seen that when we have shifted that to the microendoscopic method. The results of PCF with or without discectomy are almost similar outcomes as far as the VAS and the Oswestry's disability index is concerned over a period of about 3 months. It's basically a motion and a disc preserving surgery. I feel it is the platinum standard, way above ACDF, which is done routinely for disc herniations. Complications that I have encountered in my career: dural tear in one patient with a mild CSF leak treated with acetazolamide, did not require any surgical intervention because the moment you pull out the scope, the entire musculature sits back over there. There is no dead space left behind for CSF to collect. Post-operative epidural hematoma I had in one patient. I had to unfortunately go back in and clean out the hematoma, put in a drain. After that, I've learned to put a drain in all cervical spines, always. Infections, I've had 0. Dysesthesia and root pain, transient root pain, little numbness in the fingers, usually resolving in around 2 to 3 months is what I've seen quite often. But beyond that, no other major complications have been encountered. So how do I do it? The question is, how do I do it? It starts with the positioning of the patient. Now you'll see this weird positioning of the patient, wherein I put in a strap supporting the buttocks of the patient. We flex his knees, pull back his shoulders. If you see his eyes, they're slightly below his heart. But otherwise, what you should appreciate in this positioning is that the neck is horizontal to the floor. So when I'm doing my UBE procedure, my hands are comfortable. I'm not working at an angle. I'm not working with any steep angle of a bent neck. So I have devised this positioning and I've been very comfortable with it. I start by marking the midline. I mark the overlap of the gap, identifying the V point. I land on the lamina, identifying its lower edge of the superior lamina and the interlaminar space. After I've done that, I identify the facet and the V spot. I demarcate how much of the facet I intend to remove. Here you can see the radiology of the patient. There's a large disc herniation. In the axial, you can see there's a huge big fragment over here. It is just below the exiting nerve root. I have to land from here. I have to open up this area. I have to create an angle and a trajectory that will let me over here and let me get out this fragment. So you can see the radiology. I have marked the V spot. I have landed on the V spot with my both blunt dilators. Before the blunt dilators, I use the needles. They are coming from, their insertion points are mid-pedicular from the above and lower pedicles and landing at the V junction at the spinal minor point. Identification of the V spot during surgery, the scope behind it, resting on the facetal joint is very important, and subsequent radiology after we completed the surgery, or when we are in the disc, as a matter of fact. As you can see, there are a thin 2 mm Kerrison punch, disc punch has gone in right up till the center of the disc to remove the fragment with angulation. Post-operatively, you can see the CT scan, you can see my drain over here, the small little drain going in, small little gap over here, undercutting of the facet, opening up of the entire space for the root. Here again, you can see the cutting of the lamina under surface and the drain going in. And here you can see how much of the facet joint I have actually punched out. So I've not really created any facet instability in my procedure. This patient can be comfortably mobilized and sent home on the second day itself after removal of the drain. I will now be playing a video of my surgical technique. And after that, thank you. Thank you once again, Bonds. And thank you once again, Master Son, for all you've taught me.
Okay.
Good morning and welcome once again. I'm now going to play a video as to how do I do it. Here you see that I have landed on the spinous process lamina. I'm stripping away these tissues and I'm finding the space between the lower edge of the superior lamina and the space between the two laminas. I'm coming laterally, stripping away laterally to come to the facet joint. Our target spot is the V point, from where we will be starting the decompression of the roots, going lateral to the myelon, and then entering the disc without causing any damage to the central cord. Here you see how I'm exposing slowly the investing fascia and the capsule over the facet joint. And you can see the SAP coming in your view. The stripping of the facet joint and the investing fascia is occurring. And as I go upwards, I'm going towards the V spot. The entire SAP is in our view now. We are stripping away the capsule and we are landing on the V spot. As I pull away this investing fascia, the lower laminar edge comes in our view. The SAP is coming in our view. As we strip upwards, yes, this is exactly where the V spot is. Identification of this V spot is the key to the initiation of our surgery. And as you can see now, I have reached it by stripping away the capsule and the investing fascia. Now I'm burring away the V spot. One can see the IAP, one can see the cartilage between the IAP and SAP, and now you can see how I'm thinning away the SAP. I tend not to burr through the SAP, I just tend to thin it, identify the joints. Now I'm locating the inner edge. This inner edge, as we sweep upwards, will become the inferior lamina. The V spot is now completely open. I will introduce a small 1 mm Kerrison punch, then a 2 mm punch to gradually expose the entire working area, which is the traversing nerve root, the exiting nerve root, the axilla, and the shoulder. Once these areas are exposed, we are on our way to conduct the discectomy. Posterior cervical foraminotomy, a bit of the laminectomy, removal of some of the phlegm, targeting the disc, is the key points of the surgery. You can see how badly the traversing root here is stretched over the disc hump, even in the initial views as they come in our view. The entire spinal cord appears to be elevated, lifted, and tense. Going laterally is giving relief to the structures. Now we are in the axilla. I have probed the axilla. I'm introducing a small 2 millimeter biter, angling it into the disc, and here we are pulling out the fragment. The biter doesn't have the strength to pull the fragment out, but it has delivered it into my view. So I'll be now using a regular disc punch. I need to. Fragment is breaking. It's large for a cervical disc. You can see the C6 exiting root. You can see the C5 root. You're right in the axilla, and you can see how badly stretched out all the structures are. And here we deliver the huge fragment. Despite it being morcellated many times, it's quite large. You can see how the cord is relaxed now, how the traversing root is relaxed now, how the exiting root is relaxed. This little bleeding is occurring from the shoulder of the root. The entire root is right in front of you. A little bit of the phlebectomy has been done. You can see the exit of the root into the foramen. It's not very clean. I intend to open it up a little more to make sure that I can see both the pedicles and the root rounding off and going beyond the pedicle. That would make sure that the entire foramen is open. So a little bit of undercutting is still needed, which I'll be now doing very patiently and gently with the curved biter. Now one can visualize the entire free path of the root. I have not stripped the root of its investing fascia. I prefer not to do that because then that sets off a lot of bleeding. But you can see how nicely I'm biting into the remnant of the SAP. And as I rotate my scope now, you can see the outer and inner pedicular edge and the root going beyond it. This is a sign that I've completely freed the nerve root. The vasculature in the cervical cord is now picking up because of the decompression that we have done. I've done a little bit of phlebectomy till the midline. I don't need to do anything more there because our principal indication was a herniated disc. I hope you all have enjoyed this little video and we can go back to our lecture. I'm introducing a drain. I prefer not to have a cervical epidural hematoma at any cost. So I prefer to put in a small neck vac drain directing towards the root, foramen, and thank you very much.